One of the main questions I'm asked, aside from what's normal, is how can I tell whether the speckle tracking is accurate? This seems to be especially the case if the bullseye does not turn out as expected. There are revisions of speckle tracking technology now that display and send the moving strain region of interest in DICOM form. I personally like to store the quad screen for each view as I perform my strain assessment. The quad screen displays the strain image with the approximate value for each segment, as well as a colorized M-mode representation of the strain values and each of the strain segments plotted on a strain pressure curve. If we look closely at the strain pressure curve, we can see each of the segments for that view as they undergo the process of deformation. The peak systolic strain value will be marked by a small white box before the aortic valve closure line. The positive to negative strain scale is displayed on the vertical axis. For me, what is of most value is the curve itself. See how on the image on the left, all the strain curves undergo a similar pattern of lengthening and shortening, regardless of how much shortening is occurring. Now look at the image on the right, and in particular the blue and red strain curves. See all the noise and artifact in those curves? This is an example of what poor tracking looks like, and the strain region of interest should ideally be repositioned and reassessed, or those segments disregarded from the assessment. Now that you're aware of what poor tracking looks like, let's take a quick look at what situations contribute to this. Unless the region of interest trace is very inaccurate, I generally allow the AFI to auto-process through to the quad screen prior to making any decisions about any region of interest adjustments. Care should be taken not to place the tracking below the level of the annulus or too high into the left ventricle. The image on the left shows lower basal strain values with the tracking placed too low. The image on the right shows more accurate tracking with improved placement of the region of interest. If the region of interest width is too narrow, there will not be enough information for accurate tracking. Alternatively, if the region of interest width is too wide or placed too far out, including the pericardium, this will underestimate the strain values. Be careful also not to track mimicking structures such as the chordae, papillary muscle, or bands within the ventricle. Tracking too low into the left ventricular outflow tract may falsely reduce the strain values as there is a hinge point where the motion changes direction. The strain region of interest placement is also important in the event of basal septal thickening. Care should be taken not to follow the septal bulge as the change in direction of the deformation reduces the strain in this region. This error is amplified in endocardial tracking, so if full thickness tracking is available, this may be preferential. If the left ventricle is foreshortened or the location of the apex region of interest is not correct as per the image on the left, the strain imaging may be falsely elevated in that region. The image on the right shows more accurate placement of the strain region of interest up into the true apex, displaying far more accurate strain results. I would like to thank you for listening today. My biggest advice is to practice strain as much as practical, particularly when the image quality is good. When the strain is an important part of the patient's follow-up, whenever possible, perform the longitudinal strain assessment while the patient is still on the echo bed, so that further images can be obtained if required.